The first talk is on evaluation of an elbow patient, and we'll take this a bit in a bit elaborate way, so that we are not addressing only the postgraduate student, but also learning about evaluation to manage patients in life. Okay, so let's take this example in which we see an X-ray, and this is not an uncommon scenario. A patient comes with, or you get a WhatsApp message, or you get an email in this time of social media. And if I want to describe this X-ray, it's a X-ray of a skeletally mature patient, the elbow joint, the AP and lateral view, and there appears to be a supracondylar fracture. So although we feel the X-ray is the last stop for knowing what is to be done, however, you see how incomplete this X-ray is. Although we have the X-ray, we looking at the patient, just looking at the patient, meaning inspection of the patient. This is the patient the X-ray I had shown you. He's actually come to the clinic with a problem of a painless, stiff left elbow. All these things are important. Now, the upper limb is very important as far as dominance is concerned. So, you cannot know the dominance of a person unless you have asked in history. It will not happen even with an examination. You have to ask him. His complaints is inability to move the elbow completely. So, trying to emphasize upon all of you that every part of the evaluation, history, and examination and investigation have a pivotal role in coming to a diagnosis and then treating a patient. So, what is the function of the elbow? The function is to bring the hand in a position where it can perform its function. So, this is the prime function broadly, if we have to define, of the elbow. And if you go back to the anatomy, the elbow joint is formed by the humerus, the ulna, and the radius. It's a slightly complex joint because there is a hinge joint between the humerus and the ulna, and sort of a pivot joint between the radial head and the ulna. So it's important to keep in your mind the anatomy because that takes you towards physical examination. So the general approach to any case in orthopedics is history and examination. And examination gets divided into inspection, palpation, range of movement and measurements, and neurological examination. So let's go stepwise. History taking, although elbow comes as a short case more often than not, however, you need to balance the details of the history, small or more, which you need to pick up in a particular patient. So these are the pillars of history taking. You need to have patient data, presenting complaint, history of present illness, the past history, the treatment history, and the social history. In a long case, everything goes a bit more detailed. In a short case, you touch upon each depending upon the importance of that particular thing in the case. So let me emphasize about the demographic data of a patient. You always need to ask the name, age, sex, occupation, marital status, residential address, and when did the patient come to you. All these are important in the long run when you have to manage the patient. And as I told you, elbow is particularly important joint in the way that you need to ask one more important thing, the dominance. Is he a right hand dominant or a left hand dominant person? In the demographic data, in today's age, please add the history of COVID, history of contact, from which region he is coming. Moving on to history of presenting illness, the standard question, when you were absolutely okay, so that you can take him back to the time when the illness started. And then you ask him, what happened then? So it takes you back in the time. It might take a few minutes for the patient to actually exactly give you when he started getting problems. And in the history, especially in a case of elbow, the main presentations would be pain, swelling, stiffness, deformity. And particularly for the elbow, we are interested in certain additional history, whether there was some massage given around the elbow or whether any manipulation was done with the elbow. So these are broad symptoms which a patient would come to in an elbow pathology. About each symptom, we need to elaborate whichever is present in the patient. So we want to know the onset, the course, the duration, what treatment if he took any, and what was the response to the treatment or to the past duration he's gone through the illness. So basically, we want to know about the onset, duration, and progress of his disease in the past time before he has come to us, depending upon which symptom he's carrying. But about pain, if he has pain, if it is a painful condition of the elbow joint, we need certain extra points to be elaborated upon, and they would be site, character, intensity, and radiation. Socrates is an important mnemonic which you can remember so that you don't miss out on any character of the pain. Pain is very important if the patient has it, because even at the end of the history, you would be able to come to a provisional diagnosis, whether it is an inflammatory pathology or an infective pathology or otherwise. So you want to know about the site, the onset, the character, is there any radiation, is there any association like maybe morning stiffness, which invariably is a starting point. Elbow could be a starting point for a rheumatoid arthritis patient. The time course, does the pain follow any pattern, any exacerbating or relieving factors, and the severity, how bad is the pain. So if pain is one of the symptoms, you actually need to go into slight amount of detail, even if it is a short case. You need to know about the severity, the relieving factors, the progression, and the present status. And it's not a very bad idea if you could document the pain objectively on a scale of 0 to 10. We need to ask the patient maybe 2 or 3 times, maybe place this pain scale in front of him so that he can understand, and because this gives you a very objective parameter on how the pain has progressed. So that's something about the history. And once we go ahead, the pillars of examination are look, feel, and move. And I've emphasized on function. Now, this is one thing which is at times missed out. You need to ask the patient specifically what functional disability he is facing, what activities of daily life is having a problem, and what is the type of problem. At times, you can also ask him to demonstrate the problem if he's a particular type of a problem. That makes you understand and guide your treatment. So your examination starts with inspection. You look at the patient, and it starts as the patient walks into the clinic. Once he is with you, preferably you need to undress him and look at both the upper limbs together. Now, the second important thing about elbow examination is that you have the opposite limb of the patient to compare most of the parameters. So you want to look at the elbow from front. You can get hold of the alignment. You want to look at any scars, any swellings, any wasting. You want to look at the elbow from the side. It again tells you about some amount of alignment, whether there is the attitude is in flexion or hyperextension or neutral position. Is there a prominence jutting out from the olecranon? Is there any severe wasting in the arm or the forearm? From behind, the 3 bony points which are asked to each one, whether is there any standing out of the triceps tendon, one of the hallmarks of a neglected elbow dislocation. Is there any swelling? The elbow effusion classically comes in the paraolecranon area to start with, and then moves on to the anconius triangle. And definitely, one thing which is forgotten is the medial side. So always make an attempt to look on the inner side. Don't miss out on any scar, sinus, or any swelling or a prominence on the medial side. So look from all directions. And when you're looking, a carrying angle is one of the important things which is there with the elbow. The trochlea extends more distally than the capitulum, creating a carrying angle to the upper limb. You would find a figure which will vary in various textbooks, but if you want to have a easy way out, in males average is 5 to 10 degrees, and females it is 10 to 15 degrees. always remember a prerequisite is that you need to be able to put the elbow in extension and supination, because if that is not possible, you will not be able to appreciate the carrying angle. So we have a talk on cubitus varus, so we will have more details on this aspect there. And once you've done the inspection, you come to palpation, which is the feel. And the first point is to look for the temperature with the back of your hand and look for any tender point. Why do you do these first? This gives you an idea about whether you're dealing with an acute condition or it's a quiet elbow pathology. Because if it is an acute condition, you need to handle the person and the joint very gently. Otherwise, the patient will not be able to cooperate and you will be finding it difficult to complete your examination. So palpate for the various bony points. What are the bony points? They are the olecranon, the medial and the lateral epicondyle, and the radial head. Once you do that, you have to move across along the bones. You need to palpate the subcutaneous border of the ulna. You have to palpate the supracondylar ridges. You might palpate the proximal part of the radius. So once you've done your bony landmark palpation, you need to look at soft tissues. You might have to look at the brachial pulse. You might look at any swellings in the cubital fossa. You might go around on the medial side, palpate for the ulnar nerve and the lymph nodes, or any other swellings which you could feel. So certain things which are asked pretty often and you might be asked to demonstrate. One of them is how to feel the radial head. So this is classically done in the elbow inflection. You feel for the lateral condyle, and below the lateral condyle there is a fossa. In the fossa you feel a hard structure which on a rotation of the forearm moves with the rotation of the forearm and is very smooth and circular. So these are the steps you need to follow in palpating the radial head. The three bony point, remember this is one of the important parts in the elbow examination. You need to know how to come to the points. For the medial epicondyle, you palpate the supracondylar ridge and come down gradually, and the most prominent point would be the medial epicondyle. For the lateral epicondyle, you palpate the lateral supracondylar ridge and gradually come down. The most prominent point is the lateral epicondyle. For the olecranon, you palpate the subcutaneous part of the ulna, move proximally, and you would reach the most prominent point. Now you need to mark these points and then assess these points, comparing them with the normal opposite side. This is very, very important. The normal relationship in extension, all these points lie in a straight line. When you examine this in flexion of 90 degrees, they form an isosceles triangle with an elbow at 90 degrees. All the books say isosceles. If you read your S. Das, it says that the medial limb could be shorter. Now, for this, you always have your opposite elbow to compare. And be very careful, you need to compare both the elbows in a similar amount of flexion. If you don't do that, it would be erroneous. So the three bony points, practice palpating them, practice how to demonstrate. If somebody asks you to demonstrate, the classical way is you put the thumb and the middle finger on the medial and the lateral epicondyle and the index finger on the olecranon. So coming on to the movements, there are two movements which are to be looked into, the flexion extension and the supination pronation. When you read various textbooks, the range given in all the textbooks would vary from 5 to 10 degrees here and there. So the one good standard example could be 0 to 150 degree is a range of flexion. Up to 10 degrees of hyperextension is considered normal. Again, compare it with the opposite side. Your opposite side is the answer to what is the standard for this particular patient, unless it is a bilateral elbow condition. So for example, you can say that my patient has a range of movement of 30 degree to 90 degree, which is painless. So this is a nice way of demonstrating the range of movement. You can see that the left side is the involved side, and you can see the extension as well as flexion. So that is where you need to expose both the elbows, and this gives you a very, very good evaluation of what is the restriction. And please start using the goniometer to objectively note what is the angle of flexion and extension. You need to practice this, do it in your clinics, do it in your OPD, because if you're doing it first time in the exam, you will definitely fumble. Your body language will convey to the examiner that you have not practiced this particular thing. And to evaluate the flexion and extension, this is a nice way of doing it. You demonstrate the movement and then place the goniometer on the outer aspect of the elbow. Now comes supination pronation. Now the neutral position is considered 0, and various books again would give a different range. And you can remember that in almost everywhere the supination would be slightly more than the pronation. And remember, you have the normal side to compare in your particular case. So this is one of the ways of evaluating the range of motion of supination and pronation. You give a rigid thing like a scale or a pen to the patient. Ask the patient to tuck his elbow to the side of the torso. Keep the elbow at 90 degrees of flexion and demonstrate this movement of supination and pronation. Be careful that the patient should not extend or flex the wrist in various positions. It might be a good idea that you demonstrate this to the patient yourself first, and then he would be able to understand and do it properly. If you want to objectively measure the supination pronation, this is the right way. You need to keep one limb of the goniometer either on the dorsal or the volar aspect of the forearm, depending what you're measuring, the pronation or the supination, and the other limb remains vertical, and this gives you a very, very objective way of defining how much is the movement. So coming to the last measurements, it's the arm length, the forearm length, and the muscle wasting and the carrying angle. The carrying angle, you need to draw a long axis of the forearm and the arm. Forearm is very easy because you have bony points, the ulnar and the radial styloid, the central part, the medial and the lateral epicondyle, the central part. So you draw a line. The arm is an approximate line in the proximal area where it is the proximal point is the center of the anterior axillary fold and the attachment of the deltoid in the proximal humerus. So it's an approximate midline which is raised from soft point, so it might be slightly inaccurate. However, you need to be visually central in the line and then try to measure your carrying angle in this way. This needs practice, so please do it. Measuring the arm length, you need to always do this to complete the examination of an elbow case. The points are the angle of the acromion and the lateral epicondyle. How do you reach the angle of the acromion? You go from the midline laterally, try to palpate the spine of the scapula. As you go laterally, the spine of the scapula suddenly turns forward, and that is the point where you have the posterior angle of the acromion. Remember, there is another angle which is anterior. We are not measuring from there. We are measuring from the posterior angle of the acromion. The other point, lateral epicondyle, we have already talked how do we mark that, and you measure this by a measuring tape. Again, compare it with the opposite side. The forearm length is measured from the radial styloid to the lateral epicondyle, and remember, you need to keep the position of the forearm in the same way in the both sides, otherwise your measurements would be inaccurate. Why I'm saying this is because maybe there is some restriction of supination and pronation and you're not getting a complete supination in a patient. So the normal side needs to be kept in a similar position and then compared. So the last part, special test. Now they could be disease specific. Classically, certain diseases like tennis elbow and rotatory instability, these cases are not kept in your exam, but these could be part of your theory question. So you need to remember those specific tests like the Cosen test for tennis elbow, the active and the passive test for the tennis elbow. You always need to evaluate the distal neurovascular whenever you're doing any joint. Please palpate the pulse, do a quick check for all the nerves, specifically palpate the ulnar nerve in an elbow case. If you get a neglected lateral condyle fracture, which is there for many years, the ulnar nerve could be thickened and you should be able to pick it, compare it from the opposite side. And the last thing, re-emphasizing functional disability, you might ask the patient to demonstrate exactly what disability. For example, he might be a cook and he might tell that he has difficulty in cutting and chopping watermelons. So that tells you that there is some problem, maybe of instability or some extensor mechanism problem. So please try to identify the functional disability. So concluding with the last three slides, the presentation in an elbow case would be few like swelling, deformity, stiffness, and pain. The classical cases are going to be cubitus varus, lateral condyle fracture neglected, neglected elbow dislocation, a stiff elbow, or a swelling, painless, or a painful around the elbow. So these are the cases around which the exam would be conducted. And remember, in a short case, the questions are standard. You need to rehearse the answers of these questions before coming up for a viva. You need to know that the questions are, what is your diagnosis? Why do you say so? What else can it be? And what would you like to do? And remember, these 4 points would always be based on these 4 pillars of history, examination, investigation, and depending upon these, what treatment you will define for a particular patient. So I will stop here, and the other lectures would elaborate particularly on each particular condition. Thank you very much.